adequate, and then we have, woohoo, 11%, very high. Good for you. I will stop sharing for now. And now I would like to introduce Dr. Pope Moseley, who is a professor at Arizona State University at the College of Health Solutions. I really like the name of the college. That is an awesome name. Thank you, Dr. Moseley, and passing it on to you.
Thank you. I'm trying to, let me get my slide up here. Great. So is this on? Can you hear me and see me?
Yes. And before we start, if you all have any questions, please put them in the chat. We will get to them and you will have time to ask questions at the end.
I'm pleased to talk. Thank you. I spent most of my career at the University of New Mexico before going to the University of Arkansas and then the University of Copenhagen, and then in my retirement working at ASU part-time. I'm going to talk about something, though, that I've spent my whole life working on, which is the impact of heat on health. And I'm going to focus on substance use disorder for several reasons. We can use it as a probe, as a way to understand the real hidden impact of heat on health. And that's going to be my big message, that we're not measuring most of what heat does. But substance use disorder is especially important. It highlights the impact of heat on a population that is excluded and suffers from a huge number of health-related social needs. Surprisingly, there's very little, if you go through the literature, there's very little literature on the impact of heat on substance use disorder. And I'm going to show you how powerful heat's impact is. And so this really is one of the best models to talk about this. But first, I'm going to talk about the vulnerability to heat stroke. We're going to go through heat-related illness, and then I'm going to talk about some of the things that we don't usually talk about with heat, which is its impact on other diseases, and then finally talk about our heat center and what we're trying to do to address this. So as one of the previous speakers pointed out, that vulnerability to heat stroke is extreme of age, volume status, so dehydration, medications, diuretics, beta blockers, antihistamines, antipsychotics, all change your ability to deal with heat. And exertion in the heat, work or play, and then the important part of pre-existing medical conditions. So when we hear things like heat exhaustion, heat illness, heat stroke, and sometimes we talk about the idea that there is a progression. But let me assure you, there's no progression. You can go from being completely healthy to explosive heat stroke in 20 minutes in exertion in the heat. And heat stroke is a catastrophic illness. Here's an example of a catastrophic illness. 1995, Albuquerque, New Mexico, warm, dry conditions, a military police competition. And the time was given for the run by when the last member of your team came across. So the gentleman that's being carried across with the 6 prominently 116 is being pulled across by his colleagues after a 25-minute event. He will die the next day in an intensive care unit from multi-organ failure. So this is heat stroke. This is the best illustration of heat stroke I have ever seen from a newspaper article in the Albuquerque Journal. This was what I used to actually try to study what happens in heat stroke. So it's a catastrophic, explosive, acute illness, 20 to 80% mortality. So at best, a 20% mortality. It's characterized by multi-organ failure. Your liver fails, your kidney fails. Your platelets go away because you start clotting abnormally, and because you use up all your clotting factors, you begin to bleed everywhere. And respiratory distress. The only thing you need for diagnosis is an elevated core temperature and altered mental status. So what happens? Well, my research group spent a lot of time working on this, and we came up with the following issue. The fundamental problem is that we have about 5 liters of blood flowing through 15 liters of tubing. So we're always making choices. The body makes choices for where to send the blood. In a hot environment, as much as 60% of your cardiac output goes to the skin. So we wondered, if blood is going to the skin, it's being pulled from somewhere, and is there a critical target organ that is starved for blood and leads to this explosive multi-organ failure? Well, there was some data in the literature already showing that if you raise the body temperature, and if you look at this bottom graph, you don't really have to look at much of it. The LRA is the skin, and what it shows, and the line with the dot with the triangles is blood flow. And what you see is, the middle one is the kidney. So what the kidney shows is that it gets its blood. It doesn't get starved at all. As you go along the temperature line, it stays pretty flat. Up at the top is the skin artery, and what you see is that as temperature increases, blood flow increases, as we'd expect. The bottom one is important. It's the superior mesenteric artery, which flows to the gut. And by 38 degrees, you've already lost half your blood flow to your gut. So the blood is shifted away from your gut to your skin, to your muscle. And the problem with the gut is that it's 20 feet of bacterial-filled cannoli. So that what happens is when you pull blood away from the gut, you start creating a situation where bacterial products can actually leak into the bloodstream. And in fact, that's why heat stroke looks just like sepsis in many ways. So in 1993, we published this study, which was the idea that the blood, you had vasoconstriction in the gut. The gut barrier began to break down. Bacterial products called endotoxins moved into the portal circulation and caused the cytokine storm that we used to hear about with COVID. And that caused a systemic inflammatory response and organ failure. And this model that we proposed in 1993 is pretty much held up as the way that heat stroke works. So you don't need a whole lot of other stuff. What you need is to compromise your gut blood flow. And that can happen pretty fast. And you can get endotoxemia pretty fast. So this is it's a special illness, heat stroke, and something that can occur very fast. You're likely, if you go out on a hot day hiking, you're likely not to have it. But if you have it, it's a 20+% mortality. So the consequences are great. I'm careful in the summer when I hike, and I make sure I'm hydrated. So the implications are that this explosive inflammatory storm is driven by high environmental temperature and impaired heat transfer to the environment. Interestingly, as I'm going to talk about, states with compromised gut barrier, or we talk about the gut microbiome, people with a gut dysbiosis, with a suboptimal gut bacteria or poor blood flow, those are people who are most vulnerable to heat illness, as it turns out. If you go through the diseases that are associated with heat illness, most of them fit that. Therefore, heat amplifies numerous pre-existing conditions. And so I would say that strategies that enhance gut barrier integrity may be really helpful. And those include exercise conditioning and microbial diversity, increasing microbial diversity. Okay, Phoenix, America's hottest city. I've talked about Phoenix when I've been interviewed as ground zero for climate change, for America's hottest city. It is really, it is the place where we can study heat because it is the most important, I would argue, the most important heat laboratory in America. These are the 100 largest American cities, and these are the temperature spans. And what you see is that Phoenix outstrips them all. This is from our colleagues at the Cicero Institute for Climate Change at the University of Oslo that we work with for satellite monitoring. Here's a little, for those of you who like King of the Hill, I am a King of the Hill liker. I hope you can hear this.
111 degrees? Phoenix can't really be that hot, can it? Oh my God, it's like years on the sky. This city should not exist. It is a monument to man's arrogance.
Piggy Hill has a point. And Phoenix and Maricopa County really have serious heat issues. They have long periods of high temperatures. The rapid urbanization in Maricopa County, Phoenix especially, has driven an increase in the high lows, this urban heat island effect, which we estimate is about 12 to 15 degrees at night. It also has America's fastest growing unhoused population, has a rapid rise in combined fentanyl and amphetamine use. And then there's the issue of the Colorado River depletion. So the tenuous water supply. And although only 7% of Phoenix's power comes from hydroelectric power, that 7% is the surge capacity that is used when there's increased demand. So it has a disproportionate amount of impact when we cut back on hydroelectric power. This is just a map showing the urban area of Phoenix over time, another heat map showing the urban growth driving temperature increase. Again, satellite data of the metro area from our colleagues at Cicero. This is the difference between the span between or the rise in low temperatures. There's a relative difference from 1980 to 2015. And what you see in the Phoenix area, again, this is a heat map, is that when you are looking at the high lows, it is tremendously powerful. And if you talk to people in Phoenix who've lived there 25 years, they'll say, yeah, it might have gotten a little hotter during the day, but it just doesn't cool off. And that's a lot of that is an urban effect. And when you plot that, so if you plot, this is kind of an odd little graph where we look at year over year, the rate of change of the high temperature to the rate of change of the low temperature. And so the low temperature, if you look at a city like Houston, the rate of change of high and low are kind of in concert. But in Phoenix, the rate of change is much higher. In fact, we don't have a city that's anywhere close to this. So Phoenix is fivefold better than anything else we can find, or worse, in terms of the rise in lows versus the rise in highs. So Phoenix is the place that we should be studying this, and I think we get a lot of information that will be useful for the rest of the country, especially New Mexico, because we have areas in New Mexico that are, I would say, Phoenix-like in terms of their heat exposure. And so for the climatologist in the previous talk showed some of those Phoenix-like areas. And so just because it's a little higher here doesn't mean everybody's okay. So those lows are important. This is data from the 2003 European heat wave that killed a lot of people. And it looks at 9 cities. And what you see here is plotted the long duration and high intensity. And what you really see here is that most of the mortality, the contribution of mortality, is duration, not intensity. So intensity adds very little to this. So it's not so much how hot it got, but how cool it didn't get. So how long was it, and the fact that it didn't cool down at night. Another study, another graph from India, looking at number of days. So this is days of high temperature greater than the 95th percentile for them on 1, 2, 3, and 5 consecutive days. Until you get way up in temperatures, what you see is that duration drives a lot of this. So duration drives heat illness or drives heat death pretty well. And colleagues from our group we had a study that was published last year, and it got a lot of press. And what it said was that as long as you're cooled and have air conditioning, everything's great. But if there's a power failure, our estimate was somewhere around 800,000 residents would need emergency medical care. Now, Phoenix is pretty big, but it doesn't have 800,000 available hospital beds. So we would be really talking about a disaster. And this brings up the point that I'd like to really spend most of our time on, and that is those 800,000 people that need emergency care, they're not going in for heat illness, right? They're going in because they had a heart attack or a stroke or kidney failure or something else, because those things are all shown to be driven by the heat. So we're going to talk about how when we think about heat-related illness, we are looking at a small piece of what heat is doing to us in terms of hospitalization and death. So first we'll look at heat-related death in Maricopa County. And so you see as of 2022, and it's going up. So you see a number of heat-related deaths rising as temperatures rise. So these are counted as heat-related deaths. But if you go back in the literature and you look at, this is looking at daily mortality in London with a mean temperature, which is not a great measure, but it's the measure they used, and the relative risk of death as temperature rose. This is not heat deaths, this is just death. And so what you saw is that once you passed about 22 degrees Celsius, you started to see a rise in deaths. And this has been shown again and again. You see whether it's studies from Sweden showing that 24 hours of temperature above the 95th percentile give you an 8% rise in mortality. These are not counted as heat deaths largely. Most of this is not heat death. So again, the heat waves in 9 European countries, I showed you that study. The greatest effect on heat on mortality was respiratory disease, and 38 to 90% depending upon the city. Cerebrovascular second, cardiovascular third. Now, I'll be happy to talk at if someone's interested, but in our work, we think that the respiratory diagnosis is actually just identifying people who with poor performance status, that when people have COPD or emphysema, they often have a number of other conditions, and that what this identified was a group of more frail people. So the important take-home message is heat is the force multiplier of health vulnerability. So I'm not talking about heat deaths I'm actually not talking about what is called heat-associated death. I'm talking about just death during heat waves. And this is my little put together. So over there in the left-hand side is the Maricopa County heat deaths. That's 10% of the red box. And the data from CDC and others would suggest that heat deaths or heat-associated deaths represent about 10% of the death that occurs during heat waves. Notice all these things that everything here has been shown to increase death and increase hospitalization. Inflammatory bowel disease, bloodstream infections and sepsis, nosocomial infections, anxiety disorders, dementia, schizophrenia, heart attack, all of this stuff So that when we talk about heat-related illness and we're looking at heat illness, we're looking at about 10% of what's happening. And if we're going to make an impact, we need to, and if we're going to plan, we need to understand who is getting sick, besides the people that come in with heat stroke or heat illness. It's a really nice study you may have all seen from Nature Medicine. So this was the heat wave during 2022 in Europe. So when you look at heat-related deaths, there were about 8 to 10,000 under a very liberal definition of heat-related death for all these European countries. Excess mortality was 61,000. So if you just looked at the number of deaths that occurred during the heat waves, you had about 60, using a less conservative estimate, over 70,000. So between 60 and 70,000 people died, and we tracked 8 to 10,000 people. And that is really the big problem. So I was talking to someone about when are we going to get serious about heat? And they were saying, well, we probably need a big disaster. And my response is, well, we're having the big disaster. We just don't recognize it. So one of our goals as I'll show you, one of our goals in working on this is to show people that this is a rolling disaster right now. It's not, 8,000 people dying of heat is bad. 60,000 is catastrophic, but we don't see the 60,000. We see the 8,000. So it's our job as health professionals to educate people that this disaster is an ongoing disaster. If the hurricane last week had killed 60,000 people, it would have been the worst disaster in America. But many more than the heat-related illnesses that we track are dying of heat. And we just don't see it. And that's what we're focused on. So heat is the force multiplier of health-related social needs as well. Not only of illnesses, but of health-related social needs. So the fourth wave of the opioid overdose crisis is stimulants plus opioid. That's a terrible combination for the heat. Environmental work exposure with inadequate water and shade. Housing. The unhoused population. People in manufactured housing. So the people in Maricopa County can tell you that manufactured housing is 5% of the housing stock, but the vast majority of deaths during a heat wave in-house are in a manufactured house. And then people who just don't have the resources to cool their house. If you come to Phoenix and visit me, when I'm there in the summer, you'll find the air conditioners running all the time. I'm renting, so I'm not paying for the cooling, and I'm glad I'm not, because it is really tough to cool there. Persons with disabilities. Mobility, deaf, blind, cognitive, behavioral. People with disabilities, in the few studies that have been done, suffer enormously in the heat. And not just they don't feel good, it's death and hospitalization. And comorbidities, which are the key to phenotype. Over 60% of the US population have at least one comorbidity, and over 40% have two or more. So comorbidities, if I told you that 90% of the people are going to the hospital and dying because of their comorbidity, and 60% of the population has at least one, then we have an issue. And then the gut health issue, which I think is really important. If you take a look at me on Instagram, you'll find that I write a lot about the impact in detail, referenced in detail about how heat affects gut health. And that is a really important issue, I think. It'll become more and more important as we go forward. So unhoused versus inadequately housed. This isn't, so here's the statistic. 25% of heat deaths during heat waves occur indoors. 5% of the housing in Maricopa County is manufactured, and greater than 40% of all the home heat deaths in heat waves are manufactured. So manufactured housing is deadly because Number one, it's hard to, it may reflect income. And number two, it's not well insulated. If you fly a temperature sensing drone over a mobile home community, the roofs during a heat wave, the roofs of those mobile homes are ice blue because the cool air is going up through the top of the structure. Now, you don't have to just die or go to the hospital. This study of children adequately housed during a heat wave of 95 degrees, so much cooler than we'd see in Phoenix. 9% decline in processing speed, 7% decline in addition, subtraction accuracy. So this is considered adequately housed, just no access to AC, in a place that had a 95 degree Fahrenheit peak heat wave, that's Albuquerque. So when you talk about air conditioning in schools, and that's really not a luxury. That's and air conditioning at home for those students, it's not a luxury. It has a huge impact on cognitive function. Okay, the work we're doing right now, substance abuse disorder, the impact of environmental heat. I'm calling this the pernicious intersection of substance use, heat-altered cognition, and inadequate housing. Those come together, and you'll see from our data that it is it's shocking. So, how does heat stress alter the brain? Well, there is blood-brain barrier disruption. There's a barrier that surrounds the brain that protects the brain from having certain substances cross in. Certain drugs have to be modified in order to get them into the brain, for instance. Certain antibiotics can't go in, et cetera, because you have this very good blood-brain barrier. It begins to get disrupted by heat. High heat also can cause cerebral edema and instability of cerebral blood flow. So if you are dehydrated and your blood pressure becomes unstable, you have worsened cerebral blood flow. But again, this gut endotoxin translocation affects blood pressure and causes this sepsis-like syndrome where blood flow gets messed up and it exacerbates all this other stuff. But importantly, heat also alters the gut-brain axis. So the bacteria that live in our gut, I'm sure many of you understand this, this is our second genome. So over 99% of all the unique genes in our body are in the bacteria of our gut. And our gut produces a huge number of compounds that are required for us to sustain our equilibrium, including a lot of neurotransmitters. So unfortunately, heat causes a loss of gut microbiota diversity. And studies that look at the change in ratios of the gut bacteria, if you want to see what someone exposed to chronic heat looks like, what their gut looks like, and compare it to other states, they look like the gut of someone with severe anxiety, depression, dementia, and schizophrenia. So the gut microbiome begins to become less diverse, and certain ratios between bacteria change, and they're the same ratios seen in these conditions. And as I mentioned earlier, disease states that are characterized by loss of gut microbial diversity are at particular risk from heat. So all of these, severe anxiety, depression, dementia, schizophrenia, have increased hospitalizations during heat waves. And then you would expect people with inflammatory bowel disease during heat waves are really impacted by that. So here's where drug use comes in. So methamphetamine alters thermoregulation, alters how you sense temperature. And methamphetamine can increase endogenous heat generation. So if you were lying in your house and you take amphetamine, you actually have a little bump in your temperature. So if you're trying to dump heat into the environment and you're raising your body temperature, that's probably the wrong thing to be doing. Increased oxygen consumption, which is not good, And, you know, I'm talking about the gut type barrier disruption and increased endotoxin translocation in people on methamphetamine. Opioids alter central thermal regulation, so you don't regulate the same way. Decreased heat exchange, increased oxygen consumption, and again, increased gut permeability. It also changes your behavioral recognition of hyperthermia. But research in this population, especially with heat, is really limited. You ask, and finally, in this fourth opioid epidemic, if you check with people in Phoenix about why are they using opioids and methamphetamine, it's because if they take an opioid, they can't function. So they take the methamphetamine to give them a little bit more increased function. So this is this creates a really difficult, you're getting a double dose of things that alter your ability to thermoregulate. In addition, there's a high prevalence of comorbid health conditions. There's increased psychosocial vulnerabilities and stigmatization, housing instability. And unfortunately, in some cases, intoxication may limit access to shelters at time of greatest vulnerability. But there's really very little published data. The data that exists is sporadic and observational, and almost all the data deals with mortality. So you can count death. The data that's there can count deaths. But trying to figure out whether someone went to the hospital for drug overdose during a heat event, that's hard data to get. That's really tough data to get. And here's kind of an interesting study. This is a review of outdoor workers, landscapers, construction workers, oil and gas extraction. This was published in CDC. They found 111 heat-related illnesses. Environmental temperature ranges from 88 to 107. 46 severe hyperthermias. 38 of those 46 died. So again, when we're talking about heat stroke, we're talking about a catastrophic illness. If I told you 46 people had an illness and 38 of them died, that's a bad illness. So this is a catastrophic illness. Now, 34 of the 46 had a toxicology screen, and 9 were positive for amphetamine. It's 27%. 7 of those 9 died. And their body temperatures were 103 to 110 Fahrenheit. So drug use in the occupational setting is not zero. Again, only 34 of those 46, only 74% had a toxicology screen. We don't know about the others. And that's a significantly high mortality. Here's a study. Now, the reason I'm putting a study up from 1998 is because it's one of the few done. It's a study of the cumulative mean number of fatal cocaine overdoses in New York City. So once New York City hit 30 degrees, mortality rose dramatically. And again, this data is sometimes hard to get because it's done in small groups or in small populations. The databases are really tough to work through. This is Maricopa County by month. Oh, I'm sorry. This is Arizona, I believe. This is the number of overdose deaths by month in Arizona in 2022. All right. These are not counted as heat deaths. They're counted as drug overdose deaths. So we run along 170, 150, 180, 160, and then summer hits. 268, 316, 281. There may be other reasons, but I would offer that environmental temperature may be playing a role. This is that figure that I showed you, the above figure of drug involvement related. This is heat-related death on the top. So now we take the curve and we look at, not everybody was screened for drugs, but in the people who died, 54% tested positive, mostly for opioids, 9% for alcohol. So in fact, most of the people who died had drugs on board. And if I go back a slide, if I can, good. There we go. We go back. That Maricopa County data does not include this Arizona data. So these are not linked in databases between drugs and heat. They're separate. So those people with drugs on board who died of heat-related illness, they're not listed in this database. This is just drugs, drug overdose, considered a drug overdose death. So I hope I have convinced you that heat-related deaths are greatly underestimated. And the data and data on impact of heat on hospitalizations, it's almost non-existent. You can find heat-related death or heat-related hospitalization, but how do you find the heart attack? So we know heart attacks go up more than double in a heat wave. How do you tease all this data out so that you can actually look at the total impact of heat? Well, that's what we're trying to do with an NIH climate center. We call it Heat Equity Analysis of Threats from Climate and Actionable Policy, HEATCAP. The principal investigators are Marisa Domino, who is the director of the Center for Health Information Research, Matt Georgescu, who is the director of the Urban Climate Center at Arizona State, and me. And so you see that it's a collaboration between the College of Health Solutions, Urban Climate Research Center, Global Institute of Sustainability, the Center for Planetary Health, and also we have some wonderful partners. My old colleagues at the Center for Protein Research at the University of Copenhagen, the Center for International Climate Research, Cicero, the European Union's Climate Health Cluster, and ENBO, Purdue University's Institute for Sustainable Future, and the Max Planck Institute. And our model, our vision is that using big data, we can combine health data and climate data and begin to find solutions, begin to figure out what's actually happening and begin to craft some solutions. So the precision, I call this the precision health of heat. And it's the key to population health resilience. There's no average person. When you do population studies and you say the average person, there is no average person. The health of a population needs to be understood through individualized predictions. And individualized predictions require an understanding of the contributions of numerous factors. As an example, I've listed a paper from our group at the University of Copenhagen that was in Lancet, looking at survival prediction in intensive care units based on aggregation of long-term health data and acute physiology. So we used hospital data, we used the Danish National Patient Registry, we used electronic patient record, and together we put together actually what turned out to be a very, very accurate model of a prediction of likelihood of dying in an intensive care unit for each individual person who entered the hospital. And it worked pretty well. And we looked at it prospectively, and it gave a very accurate prediction. So that's the kind of paradigm you can use to begin to look at not just health data, but also climate data and housing data and exposure data, and begin to model individualized predictions for people. Because I don't, if I go to the doctor and the doctor tells me I need to be on a drug because there was a randomized controlled trial, well, the randomized controlled trial might show that I'm in a group, but it doesn't say anything about me. And in order to know about me, I think we need to think more in terms of individualized data. So this is what we look like. We have health record data, hospitalizations, prescriptions, ICD-10, readmission rates, death. We have climate data. We have geolocation, thermal burden. We have housing data, manufactured housing, single versus group housing, proximity cooling centers. We have wearable data, pulse data, sleep data. All that goes into our data warehouse. And then using an AI machine learning system, we're starting to develop a look at heat-sensitive phenotypes, thermal conditions driving hospitalization. So when we talk about a heat event, remember that heat events are just, they are something that we have certain temperature criteria, but most of that data, if you look back, was generated from soldiers to see what happens to keep military recruits from having to go to the hospital or be pulled out of training. That has very little to do with a 60-year-old diabetic with 3 heart attacks. And so we're trying to pattern out better, more precise thermal conditions and then individual outcome probabilities. So this links climate data. So here, the work in the first year was just linking local climate conditions to hospital use. We use wet bulb globe temperatures, which are really a measure of heat stress in direct sunlight, and they take into account, as you see, there are climatologists here much cleverer than I, but they take into account a lot of the other things other than just a temperature measurement. And there's arguments for and against these, but that's what we're using. And we have, in Arizona, we are fortunate. We have the Arizona Medicaid database tied in and available for us to use to work on heat-related illness. And so this database, plus some other databases, combined with high-resolution climate data, has been our first cut. So here's what happens. This was a sort of first information. This is what happens. So on the bottom is wet bulb globe, and on the left is number of hospitalizations for heat-related illness as temperatures go up. Over here, we had 0.5 hospitalizations per day. So this was and this data actually tracks pretty well. We used the death data, and we were able to build our model and then compare it to the state's heat-related death data, and it tracked very well. This is what happens with stimulants and opioids. So over here, you'll notice that on the y-axis, it's not 0.5, it's 8. It starts at an earlier temperature, and it's much more powerful. So there are a lot more people going to the hospital during these temperatures with substance use than there are for heat. And that's kind of what we would expect. So these are big, big numbers. These 8 hospitalizations a day, hitting these as we go up. Big, big numbers for hospitalizations. So this combined climate and health data warehouse allows us to look at the impact of climate on individual diagnoses, the impact of comorbidity interactions, so we can define a heat-sensitive phenotype and build those prediction models. And we can use hospitalization data to better define physiologically relevant conditions. So I don't care so much about what's going to keep my job is not to worry about what keeps an athlete from training. My job is to figure out what's going to drive someone with heart disease into the hospital. And I'd argue that the precision health of heat is really the key. But there is a limit. So my colleague at Purdue, the director of this climate center, Matthew Huber, wrote a paper back in 2010, which I strongly recommend you read. He's a paleoclimatologist. And Matt says that in this paper, when he looked at mammals across the eons, that wet bulb temperatures above 35 degrees Celsius for extended periods make life untenable. So humans just cannot live in a world above 35 degrees Celsius wet bulb. Back in 2010, he noted that, oh, well, this isn't happening very much. Well, it is starting to happen over the last 10 years, especially, say, in the Indian subcontinent. So here's the problem with the resilience paradigm. Resilience is about getting better. So I perceive that I am training myself in the pool and I'm getting better. What I don't understand is that there's a lid on the pool and the water's filling up. So when I hit 35 degrees wet bulb, it doesn't matter how resilient I am, I'm no longer able to tolerate this. And Matthew would say that 35 degrees is the optimal. So that's the fit, trained person. His worry is that when you start hitting temperatures where the fit, trained people fail, then there's no one to help manage for the less fit, frail people. And so things fall apart pretty fast. His final quote. I talked to him, we were at a conference together a couple of months ago. If changes are implemented, our future is a +3 Celsius world. But we already know what a +10 Celsius world looks like. No mammals, only turtles and crocodiles. So I stop. I guess I can take questions or whatever. Again, you can contact me by email. On Instagram, I write about, I do a lot more detail about exercise and heat and what happens. So thanks very much.
Thank you so much, Dr. Moseley. That was amazing, extremely interesting, really. I'm going to go through a few questions that are on the chat. So please, if you have questions, put them in the chat. You can also raise your hand. We'll try to flag you. I have one that I thought was very interesting. I'm going to start with it. Why is there so little data? And what can we do to improve this?
Well, yeah, so there is data. It's just how we use it, how our access to it, and how we can work with it. So first of all, in Denmark, where I worked for several years, we had access to it, every person's record. It's a complicated system to opt out. So you had all the data, you could do a lot of stuff. But even then, so when we're doing our studies on substance use hospitalizations or substance use visits to the ED, that's everybody with a substance use diagnosis going to the ED. Well, some of them are going because they're getting a wounds sutured. Some of them are going because of a whole lot of reasons. You have to build the machine learning model to do what you want it to do, which is only find the people who came in for during a heat wave who came in because of the drug issue, not of and literally we had over 120 different other diagnoses that we had to clear out. So part of it is putting the data sets in a form that a machine can actually work with them. So there's a lot of data out there. A lot of the data is unavailable because it's in so many places and so hidden behind firewalls. But this was the reason that the electronic health record was put together. It wasn't to make the lives of caregivers easier. It's harder to work with electronic health record. But the idea was that we could begin to do planning for populations. So we're trying to do that with the health record, but it's not just health records. I mean, we're fortunate at ASU because we have housing data. We have a complete data set of manufactured housing, and we have some other advantages that have really allowed us to build this center.
Okay, thank you so much. I'm finding a few questions, so I'm not reading them in any particular order, just as I flagged them. Someone's asking if you could please share your PowerPoint presentation. And someone asked, what is the impact of cannabis on folks with heat-related illness, if there's any data on that?
Yeah, I don't know of any particular data other than mood change. I'm not aware that cannabis alters thermoregulation. Someone may know more about that. It's just something I haven't delved into. But anything that alters your perception in a hot environment might be a bit scary. I mean, there are a lot of other, besides cannabis, again, there are a lot of drugs that we don't think about, like blood pressure medicines for diuretics, antipsychotics, serotonin reuptake drugs that are given for tons of reasons. Those all alter thermoregulation.
Okay. Thank you. So someone asked, so the actual cause of death is septicemia due to blood being shunned from the gut and causes gut barrier deterioration, allowing the gut to the bloodstream. So they're asking for a little clarification on that.
Yeah, so I mean, I've spent a career doing that research, and so what happens is it's not septicemia, because what is actually happening is you get little the walls of the bacteria which carry a molecule called endotoxin. Those endotoxins are the holes that are in the gut are large enough to allow the endotoxin molecules in. And in a number of studies, we've shown that if you make the gut barrier, so people who have in heat have very high levels of these inflammatory cytokines. If you improve gut barrier resistance, you don't get those cytokines. And molecules that come across, you can measure endotoxin in the portal circulation. And so it's not septicemia. It's an inflammatory condition caused by the immune system's response to endotoxin. So we don't believe, and there's no data that you get bacteria in your blood. What you get are the warning signals that our immune system was built on, which is endotoxin.
Okay, thank you. Someone is asking, do medication stimulants affect heat to the extent of drugs-related methamphetamine?
Yes.
Drug-related.
Yeah, so methamphetamine, for the reasons I mentioned, it causes gut barrier leak, but it also generates temperature. So you can generate a temperature with that. So going out in the heat and taking something that will raise your body temperature is not a great strategy either. So methamphetamine is particularly bad, and when combined with opioids is really bad.
Yeah, stay away from drugs, kids. I'm going to ask a personal question because I was in Manaus. For those of you that haven't been there, it's in the heart of the Amazon. The average temperature is 90 degrees. That's average. How much does heat adaptability come into play? Do we get, and air conditioner is really not a thing. Trust me, I was there, and it's like fans. They have fans, and they're not great.
Yeah, so heat adaptation is really important. You can do it by living in it or by exercise. And those, you sweat more, you sweat at a lower temperature, you have a different blood volume. There are also a number of cellular processes that change that allow you to actually continue work in the heat. So a number of things happen, and exposure to the heat. That may be why, honestly, why Phoenix isn't as bad. It isn't a worse climate disaster. It's Bobby Hill, when he jumped out of that car and said it was like standing on the surface of the sun, he hadn't been in Phoenix, so in the cool, and got exposed to it suddenly. And that is, feels like standing on the surface of the sun. But someone who's in Phoenix, who's acclimated, that person may have adapted better. They understand they're drinking a lot more fluid because they're sweating a lot more. Their blood volume is higher. So, and there's some other folks here who can also speak to that. That's a whole discussion about heat adaptation, but yes, that is correct.
Okay, because they seemed very unfazed while I was dying.
Yes.
I see that we have a couple people who've raised their hand.
Can you call them out since
Sure.
I can't see them, Shelley?
Dr. Paul Charlton first, then Lindsay Keeling.
Hi, Dr. Moseley. Thank you very much for the presentation. Some of the discussion happening in the United States has been around climate related issues has become quite partisan. Health is a topic that, as your presentation today shows, heat as a topic is pretty clearly has a lot of health connections with it. And when we look at some of the future projections of how hot things could get, as the end of your presentation showed, it's quite alarming as to the impacts and the survivability of that. How do you respond to health professionals who have been a little bit nervous to engage due to the partisanship on these issues with policymakers, given what we know and that you're presenting today?
Yeah, well, I mean, I think that again is part of my driver in showing that there's a disaster going on, and that if you look, there is there are some extreme views sometimes that talk about, well, 525 heat deaths in Phoenix. It's sometimes in the most cruel, it is the undeserving poor. And we can, I mean, it is what it is. What is really happening, though, is that the population, so those, first of all, those people need to be protected. I mean, that's a physician's job, a healthcare worker's job. But bigger than that, for someone who's talking about policy, I'm not arguing with them over 525 deaths. I'm arguing with them over the 60,000 people who died in Europe in 2022, and probably the 12 to 15,000 Americans who died of heat last year that we didn't count. So when we count heat-related deaths and we say, "Oh wow, there were 2,000 deaths," that's a part of what's happening. The crisis is that we're not recognizing the impact on outdoor workers. You know, in extreme heat, when people who take care of the power grid can't work and power begins to fail, there's going to be as our studies of Phoenix point out, there could be a big equalizer, which is a power failure. And when that happens, you know, I'm hoping we don't have that, but that is the kind of, if you're not thinking about this, if you're thinking about 500 deaths from heat, you're missing all the illnesses. You know, we spend so much time in the talking about nosocomial infections, hospital-acquired infections. Really good study from Germany, 35% increase in nosocomial infection during heat wave. So all the stuff that we worry about as physicians, as a physician, you know, and I know, I'm an ICU doc, when we had a heat wave, the hospital filled up. But it didn't fill up with heat-related illness. It filled up with the regular stuff, just a lot more of it. And that humans are best, great human trait is pattern recognition. And that pattern, most anybody working in a hospital knows. You have a heat wave, the hospital gets full. That should be telling us something. That pattern is an alarm bell.
We have a question from Lindsay Keeling and then from Dr. Fabiano Amarim, and then we'll end the session. Claudia?
Okay, Lindsay?
Hi, Dr. Moseley. Thank you so much. I have a question about infants, especially since you've been talking about the microbiome and infants that don't have a fully matured and developed microbiome. Can you speak about how heat affects infants, and can it have long-term impacts on their microbiome development if they're subjected to excessive heat when their gut is developing?
Oh, that's a great question. I don't think there's data on that. I will argue, we always know that heat illness, you know, I've spent most of my career, as Fabiano was a student with me. I spent most of my career working on the gut and heat. And we know that infants are at high risk of heat-related illness. I would argue that the gut, it plays a role in that, and that an undeveloped microbiome may actually be an important factor. And that's why what you see in a number of illnesses, if you were to dig through some of my papers, you'll see that if you do things that protect the microbiome and protect the gut, you change what you don't get any more gut leak. You don't get any more endotoxin flowing across. So these are really, really important things. And I think there may be a role for the gut. It's just that we haven't recognized it yet. But I think that's a really good question.
Okay, Fabiano, and then we're gonna have to take our break.
All right. Good morning, everyone. Pope, it's great to see you talking about this. It's a pleasure and a great presentation. And I have it's a question, but it's something that as a physician, I think is important to let them know, like everyone knows, how hard is to say that someone died from heat stroke or heat exhaustion. What I'm saying is, because imagine if you have someone walking on Central Street, Central Avenue, and then the person collapse. And then you have probably 20, 30 minutes on for someone to recognize and the service to attend that person. If that person is going to be called on, let's say the person died, on how as a physician, and then let's say getting that person to the hospital, you're going to say that that person died from heat. Why I'm saying that? Because in Brazil, if you see the data from Brazil, there is 0 death from heat. And one of the problems is that they don't recognize that. I just want to hear you as a physician on what is the problem with the system also recognizing that people die like because of heat stroke, but they are not even put in the system as a heat stroke death.
Well, thank you, Fabiano. This is going back to the original question about data and the miscoding that occurs. So we coded people with heat deaths. Over half of them had positive opioid screens. We coded people for opioid deaths, which tripled in the summer. We coded someone for a heart attack, but it happened during a heat wave, and we know that heart attack deaths go up in heat waves. Suicides go up 1 to 2% during heat waves. So the impact of heat on a suicide is the same magnitude in the opposite direction of the best developed suicide prevention programs. So a heat wave will do in the opposite direction as powerfully an impact as the best suicide prevention programs. The data, there's a lot of randomness in the data. Another one of the reasons why we use the Arizona Medicaid database, where we have about 3.5 million people, is because I will quote Vladimir Lenin that quantity has its own quality. When we did our work if you were to dig up my papers, you'd find a bunch of papers from Denmark where we're looking at sepsis. Well, if you look at a study from a multi-center trial of sepsis, you'll find a big one with 1,500 people. Well, we use 30 years of data from all people in Denmark of 108,000. So yeah, there's a lot of miscoding, and this is one of the real problems in trying to figure this out. We can always back down to all-cause mortality, just how many people died during what we consider a heat wave. And that is one way to really look at it. That's something we're doing and so others are doing. And the results, as you saw from Europe, are striking.
Right. At least 10 times more people died, right? Thank you so much, Dr. Moseley. It is time for a break at incredible cutting edge research on the impacts of heat on health.
Please fill out the evaluations, and also please come back at 10:30 Mountain Time. There is more to come.
Yeah, then the evaluation is only for people who aren't coming back. Please come back.
Yes.
The evaluation at the end. It's not by session. And thank you all for being here and for learning about this critical climate change and health issue.